We're going to see the acute respiratory distress syndrome. This could be part of the post-operative complications or could be used by other causes, like most of the times it's due to sepsis or trauma, injection of toxins, pancreatitis, drowning, many things that can cause this. The significance in the diagnosis is that we will have, the acute respiratory distress. On the chest X-ray, we will see infiltrates, bilateral infiltrates, with edema. Maybe a little bit of edema, but there would be no, we'll have edema, non-cardiogenic. So the pulmonary wedge pressure would be normal. And this is in usually within 1 week. Within 1 week of the insult. Most of the time it's 12 to 48 hours the initial presentation. But usually if the patient has like this clinical presentation before 24 hours, we will consider it more a pulmonary contusion rather than acute respiratory distress syndrome. The clinical presentation would be the acute respiratory distress with high pitch rails, maybe cyanosis, and clinically we have like 4 phases. In the first phase, usually the patient is asymptomatic and only would be a respiratory alkalosis due to the hyperventilation. On the second phase, now the patient has hypercapnia and continue with the high ventilations, hyperventilations, but now is beginning to get a failure of the respiratory system, not yet completely. In the third stage is in which now the patient has, beginning to have the respiratory failure, and here we will listen the rails. In the stage 4 is now when we have the severe respiratory failure and the acidosis. Now respiratory acidosis, because now the lung system is not working. Now the treatment is aimed to maximize PEEP, the positive and expiratory pressure. We have like 2 kinds of management. In one management we manage oxygen and in other we manage ventilation. In the management of oxygen, if we have less than 60 millimeters of mercury of a partial pressure of oxygen, we will manage it with the PEEP, positive expiratory and pressure, because we don't want to increase that much the tidal volume, so we prefer to give pressure. If it is greater than 90 millimeters of mercury, then we will decrease the fraction of inspired oxygen. On the other hand, if we will manage the ventilation, here depends more on the continuous positive airway pressure. If this is less than 7.25, or if the CPAP is greater than 7.45. Usually, or maybe we can maintain to have it above 5 centimeters of mercury and 5 centimeters of water. But anyway, if it is low, we will try to increase the respiratory rate, and last resort will be to increase the tidal volume. On the other hand, if we have a high CPAP, the first resort will be to decrease the respiratory rate, and the last resort will be sedation. Here the most important thing is the PEEP, maintenance of the PEEP. Yes, we could do mechanical ventilation. In the mechanical ventilation, we try to do it at 4 to 6 cubic centimeters of water per kilogram. And we don't want to increase very much the tidal volume. So this is the acute respiratory distress syndrome. This can be caused by many could be caused by many issues. In a sense, it is a diagnosis of exclusion because it's non-explicable causes of respiratory failure. The patient could be extubated or take out of the positive inspiratory airway pressure when the patient has passed a trial of the for extubation. So we talk about this in other videos. If we know what was the insult, is getting better. If the patient is trying or already passed a respiration, things like that can aid in the patients to get out of the treatment now.